Welcome to the Radiology Advances podcast. Today we're getting into the weeds of yttrium-90 radioembolization for liver cancer and asking a question that has real implications for how interventional radiology departments organize their workflows. When do we actually need to measure lung shunt fraction on every patient?
The paper is When is Patient-Specific Lung Shunt Fraction Necessary in Y90 Selective Internal Radiation Therapy of Liver Cancer? Published in Radiology Advances. It's by Matthew Allen Thomas, Ryan Lee, Christopher Malone, and colleagues from the Mallinckrodt Institute of Radiology at Washington University in St. Louis, in the United States.
Let's start with the basics. What is lung shunt fraction and why do we measure it?
When we deliver yttrium-90 microspheres into the hepatic artery to treat liver tumors, some fraction of those microspheres ends up in the lungs through arteriovenous shunts within the tumor. Too much, and you risk radiation pneumonitis. So before treatment, you do a planning procedure where you inject macroaggregated albumin, or MAA, tagged with technetium-99m, image it, and measure what fraction of the activity ends up in the lungs.
That's the standard MAA workflow.
Right. Traditionally with planar imaging, which has known accuracy problems, and increasingly with SPECT CT, which is more accurate. Either way, it's a separate procedure on a separate day. The patient comes in for the MAA injection and angiographic mapping, you image, you calculate the lung shunt, and then you bring them back another day for the actual yttrium-90 administration.
So there's been interest in collapsing that into a single session, the so-called no MAA workflow.
Exactly. Several groups have shown you can skip the MAA injection entirely for selected patients. Typically, small hepatocellular carcinomas under 3 centimeters, without macrovascular invasion. You assume a nominal lung shunt of 4 or 5%, do the mapping angiography and the yttrium-90 delivery in the same session, and outcomes have been comparable to the traditional workflow, with lower costs and better access for patients.
But that only applies to a narrow slice of cases. What this paper is doing is trying to figure out more broadly which patients actually need the MAA-based lung shunt measurement and which ones don't.
That's the core idea. They propose a new metric called LSFbound. And the beautiful thing about it is that it's purely a pre-treatment calculation. No MAA injection required.
Walk me through what LSFbound actually represents.
When you plan a yttrium-90 case, the maximum dose you can deliver to the perfused volume is limited by 2 things. First, a maximum liver dose threshold called liver max. Second, a maximum lung dose threshold called lungs max. LSFbound is the lung shunt value at which the lung dose threshold starts being the limiting factor, instead of the liver dose threshold.
So below LSFbound, the lungs don't matter for treatment planning.
That's the key insight. If the patient's actual lung shunt is below LSFbound, then the liver dose threshold is what's constraining your treatment plan, and the precise lung shunt value doesn't affect the achievable target dose at all. You don't need the MAA measurement.
And LSFbound depends on what?
Only 4 things: liver mass, liver max, and lungs max. Perfused volume size has no effect, which is a useful property because you can calculate this before any angiographic procedure happens.
Liver and lung mass you get from diagnostic CT. Liver max and lungs max come from your institutional dose constraints.
Right. They used 20 gray as the lung dose threshold with SPECT-based lung shunt measurement, and they tested a range of liver dose thresholds.
Okay, let's talk about the cohort. What did they look at?
A retrospective single-center series. 354 cases from 297 patients treated with glass yttrium-90 microspheres between September 2022 and June 2025. They categorized cases into 5 groups: small HCCs under 3 centimeters, mid-sized HCCs between 3 and 8 centimeters, large HCCs over 8 centimeters, any case with macrovascular invasion, and non-HCC cases like colorectal metastases.
That's a pragmatic stratification. It mirrors how interventional oncology thinks about these patients clinically.
And it matters because the probability distributions for lung shunt vary by category. Small HCCs almost never have high shunting. Large HCCs and tumors with macrovascular invasion are where you see the highest shunt values.
So what did they find? How often does the actual SPECT measured lung shunt exceed the calculated LSF bound.
For HCC under or equal to 8 centimeters without macrovascular invasion, and for non-HCC cases also without macrovascular invasion, the median probability that the measured lung shunt would exceed LSF bound was 1% or less, with a maximum of 4%. That group is 87% of all the cases in the cohort.
So for the vast majority of patients, the lung shunt simply isn't going to be the limiting factor on treatment dose, and the MAA workflow isn't adding clinical information that changes the plan.
That's the conclusion. They also did a receiver operating characteristic analysis. The question was, if you used LSFbound prospectively as a screening tool, how well does it predict which patients actually have a meaningful lung shunt problem?
And the results?
Excellent. At liver max values up to about 180 gray, LSFbound achieved 100% sensitivity, meaning no false negatives or missed cases where lung shunt would matter, and specificity above 60%. So you can confidently identify patients who can safely skip the MAA workflow.
The exception being?
Large HCCs over 8 centimeters and any tumors with macrovascular invasion. Those groups had higher observed shunt values and lower calculated LSF-bound thresholds, so the probability of the shunt mattering clinically was substantial. Those patients still warrant the MAA-based measurement.
They put together a proposed clinical workflow built around this.
They did. The flow starts with the tumor category: type, size, presence of macrovascular invasion. If the case is one where multi-compartment dosimetry would be needed anyway, like a large tumor or a whole liver treatment, you go straight to the standard MAA workflow. Otherwise, you compute liver volume from diagnostic imaging, estimate lung mass either from CT or assume 1 kilogram, and calculate LSF bound.
Then you compare to the tumor category-specific probability that the shunt would exceed it.
Right. If that probability is below your institutional threshold, you can opt for the no MAA workflow. If it's above, you do the MAA-based measurement.
Now, what are the caveats here? This is a single-center study.
That's the first one. Single center, retrospective, and the smaller tumor categories had limited numbers, especially the large HCC and macrovascular invasion cases. So the probability estimates carry some uncertainty. They emphasize this needs multi-institutional validation.
They also only used SPECT-based shunt measurements.
Right. Many institutions still use planar imaging, which tends to overestimate the shunt. The LSF-bound framework should still apply, but the probability distributions would need to be recalibrated for planar data.
And only glass microspheres, no resin cases.
Correct. The MAA-based shunt measurement itself is independent of which microsphere device you use. But treatment volumes and target doses differ, so the LSF-bound thresholds would need adjustment for resin yttrium-90.
One concern with skipping MAA imaging is missing extrahepatic shunts to the GI tract. That's a real clinical risk.
That's a fair concern, and they address it. Modern interventional practice has shifted toward angiographic and cone beam CT techniques as the gold standard for identifying extrahepatic shunts, which happen during the same procedure as the yttrium-90 delivery. So that piece of the puzzle is covered.
So the bottom line is, for most patients, the MAA workflow is doing work that doesn't change treatment planning.
And LSF-bound gives you a principled, pre-treatment way to identify which patients fall into that group. It's a nice example of using the math of the dose constraints to figure out when a measurement actually matters.
Thanks to Matthew Allen Thomas, Ryan Lee, Christopher Malone, and colleagues for their work published in Radiology Advances. If you're enjoying the podcast, please rate, review, and subscribe so others can find us. You can find more from the journal at academic.oup.com/radadv. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill for accuracy.